people that haven't been on here before, and just kind of making a little introduction. So if you tell us a little bit about yourself.
Well, good morning. Happy New Year, friends. I am Dr. Kim Butler-Willis, Director of Community Health at Roper St. Francis Healthcare, and I've been there for 7 years now.
Great, thank you.
Kevin, we're good.
Okay, great. Well, I'm gonna call the meeting to order then. We are now up on YouTube, so I appreciate everybody joining us. Happy New Year. I hope everyone had a good holiday and hopefully got to spend some time with family and friends, and hopefully everybody's ready to jump back in and get back to work. But Happy New Year, and thank you so much for being here. I know it's busy for a lot of people when we jump back after taking some time off. So we very much appreciate your time. And I guess I'll make a motion that we approve the minutes from December 8th. Paul sent those out, I think, yesterday or earlier this week. If someone would second that.
A second.
All right, thanks. Everyone who approves, please say aye. Aye.
Aye.
Aye.
Aye.
Any objections? Okay, great. So we are fortunate, as I was saying earlier, to have a group here from NYU, and they're going to be talking to us about using data on health and its drivers to understand and take action on health disparities. And I guess I'm going to call on, and hopefully I'm pronouncing this right, Shoshana Levine, and let Shoshana take it from here, if you would.
Hello, and yes, that's correct. I'm Shoshana Levine. I'm the program director for the City Health Dashboard here out of NYU School of Medicine. I've been with the dashboard for about 4.5 years here, and I'm joined today by Becky Ofran, who's our manager of engagement and partnerships, and Jacqueline Betro, who is our newest team member, literally started on Monday, and is our senior project coordinator. So we're really excited to be here to tell you more about our work, and really learn about ways that we can support you as well. So the City Health Dashboard really came out of some work that colleagues of mine were doing with the National Resource Network, which was a group working with economically distressed cities that came out of HUD in the Obama era. And they were talking to cities and trying to figure out what their priorities were. And they were hearing a lot of, we know that there are health issues in our communities, but we just don't have the same type of data on health and drivers of health as we do on things like education or economic security and things like that. And what we realized was that a lot of the health data that was being released on a national scale, cities were collecting some of their own data, and big cities, especially like New York City Department of Health has an amazing epidemiology department, and they collect a lot of their own data. But once you get much below that, it's really hard to get the really robust types of data that was being released by these national surveys and national organizations out of the CDC. And all of that data is really being released at the state level or the county level, which isn't necessarily the right unit of decision-making for cities. So we developed the City Health Dashboard, which initially launched in January 2017 as a pilot for 4 cities. And then in May 2018, we launched for the largest 500 cities across the US. And then just in April 2020, so just under a year ago, we lowered our population bound, and we now have over 750 cities included on the dashboard. And it's all cities with populations greater than 50,000. So when we say cities, people think of New York or Chicago or some of these big cities, but we're really talking about a range of different types of communities across the country. And we really wanted to put these health data in context, and you'll see what I mean in just a second. I'll pull up the site and show it to you. And so we have about 40 measures, and we have traditional measures of health, like obesity, diabetes, high blood pressure, things like that. But we also know that there's so many community factors that impact health. So we have measures of the built environment, which I heard somebody here is head of built environment. We have measures of childhood poverty, of food access, of all of these things that we know are so intertwined with health, but often get siloed and presented so separately when you're kind of trying to work on these issues. So I'm going to dive in and give you all an overview of the site. I'm going to go through it really quickly just to make sure that I can show you as much as I want to show you. But I think there'll definitely be time for questions. And if I'm going too fast, feel free to stop me and jump in even while I'm going. So I will bring this up now. I'm going to share my screen, and you all can see City Health Dashboard. Great. So it's a free website. So all you need is an internet connection to be able to access all of these data, cityhealthdashboard.com. And you come in, and the idea is to be able to kind of get right into your city. So we're in Charleston today. So that's where we'll go. You start typing, click here. And I'll just pause here for a minute. I mentioned kind of all of those factors are 40 measures that impact, or those health outcomes and then drivers of health. So you can see here, there's a lot going on, and I'll let you all just take it in for a second, and then you can explore on your own time as well. But we have measures like breast cancer deaths, high blood pressure, excessive housing cost, 2 different measures of unemployment, which I can go into later if you're interested there, physical inactivity, a number of measures of the physical environment, lead exposure, park access, as well as a number of clinical care measures. So I'm going to start with life expectancy, which we often think of as kind of this really totalizing measure of health in the community. So we don't necessarily, rank or compare cities, but we know that this measure can be important for understanding kind of this overall picture of health within your city. So just to orient you a little bit to the site, here's just a little bit of information on the city. Our navigation bar up here, some information about the measure. And if I expand that, you can get a little more detail. And then if you click here with this complete metric information, that will take you to a one-pager that we developed for all of our measures that really gets into how we measure it, why we measure it, and some of the pros and cons of choosing this particular metric to get at that construct. So then we get down to the data, which is really the most important thing that we want to see. And this scale bar is what we use to present data across the site. And you can see here, this gold bar represents the city or census tract value. And the number here with this blue triangle is a dashboard city average. So Charleston is just below that dashboard city average, 78.8 years versus 79. So it's a little lower. It's not a huge difference there. And you can see here, this blue check mark indicates which way you would want to move to improve outcomes. So for something like life expectancy, obviously a higher number, a longer life expectancy would be better outcomes, whereas something like an obesity rate, a lower number would be better outcomes. And you can see here that even though Charleston is right about average, it's a little below average, the range of values here is pretty wide and goes from 66 years to 85. And if we scroll down, we can see the map, which has more detail about that. So we have for about 2/3 of our measures, the data is broken down by census tract. So these are areas, they're smaller, they're generally smaller than zip codes, and they have somewhere around 4,000 people in them, and they're administrative units. I'm sure most of you are familiar with them, but not everyone is. But you can see here, and I'm sure this map will look familiar to you if you know your city well. We can see a lot of these patterns measures such as life expectancy, or a number of our other measures where we know that the communities that are struggling in one area can often be struggling in another area as well. So if we hover over, we can see, so this looks like the darkest census tract in zip code 29405. Life expectancy is only 66.6 years. And if I click that, sorry, I have to scroll a little bit, we can see it adds it to the list here. And on either side of it, the census tracts right here, the value is 77.4 years. I can click that and line it up there. And on the other side, it's 81.1. And so you can see here that these census tracts that are literally right next to each other have such a range in life expectancies. This one over here, 77.4, is much closer to that dashboard city average. But we go from down here just above 66 years to over 81 years in just a small geographic area there. So we find these maps just super interesting for understanding what's going on in these neighborhoods, and really trying to focus down on focus resources, and that's, you know, monetary resources, but also programmatic or time. You know, nobody has enough of any of those, to where the needs are the greatest. We also have maps by information by demographic detail for about a third of our measures. Life expectancy doesn't have that, but I will show you our uninsured measure actually does, and Charleston is doing well. You can see overall in insurance rate, it's lower than, or the rate of uninsured residents is lower than the national average, which is a positive. But if we break it down by race, ethnicity, you can see that there's a lot of disparities by racial ethnic group. And so that gives you another way to delve into the issues in the community. So I'm going to go back to life expectancy and go to our compare cities map, or our compare cities feature. It's taking a minute to load. So we heard a lot when we were developing the site, you know, we always get compared to the city just because it's right next to us. And we don't think it's a great comparison. They're much bigger, they're much smaller, they're much wealthier, and we can't ever do as well as them. And it's just frustrating. And we want to have a better comparison city. So we have two ways to do that. You can, if you know the city that you want as your comparison, you can type it in here and pull it up, or we have a number of different filters, and you can choose maybe a city of a similar population size in the same region. And you can see here those numbers went down here. And we have 14 cities that match us here, and we can choose maybe Coral Springs, which is actually right near where I grew up, and Savannah, Georgia. And as we click on those, it actually adds them down here. And we can see that Coral Springs is doing better than that dashboard city average, and better than Charleston, where Savannah is not doing as well. So we can use these as a benchmark. We can use these, you know, to reach out to people in those cities and think about, you know, what are they doing that's working there that maybe we could implement here. So it's a way to really think about where you are compared to cities that are like you in ways that are important to you. We also have the ability to compare metrics. So for something, I heard a lot of physical activity when people were talking about where they're from and what they do. So we can choose our physical inactivity measure here and compare these two measures. And we have two ways of doing that. One is a map, which can sometimes be a little bit hard to interpret, but you can see here, this is kind of going to give you a visual trend where those darker colors will be poorer outcomes and the lighter colors will be better outcomes. And it looks like where there are the darker blue polygons, those census tracts, tend to have also the darker red dots. So we would interpret that as places with lower life expectancy also tend to have more physical inactivity. And if we also present that information, this I find a little bit easier to interpret sometimes, the scatter plot view. So we can see that there is, if we kind of visually put a line in there, there is a trend here that we're seeing with tracks that have, again, more physical inactivity with lower life expectancy. And so we can also click into any of these dots, see the information, the life expectancy and physical inactivity rates in there, and get more information there. And then finally wanted to show you our take action page, because we heard a lot of, great, so you told us we're not doing well in this area. We obviously need to do better. We need to do something. What do we do now? So we wanted to really fill in that now what. So we have a number of different ways that you can do that. First, looking at programs and policies. And there's a lot of different things that impact life expectancy because, again, it is this really totalizing measure. So you can filter that perhaps by local government, and that cuts it down. Do you want a policy change, programmatic change, and filter it down and scroll through in there. And if you do know, perhaps, again, that you wanted to look at physical inactivity as a way to impact life expectancy, you could change your metric. And that would give you a smaller number of maybe local government policies you could implement there. We also have, the what you can do and also how you can do it. So thinking about the partners who should be at the table, different strategies, science writing, talking about social determinants of health. So there's a lot of communication, a lot of advocacy information in there for different audiences. We try to keep up different funding streams here. We know there's never enough funding for public health work. And then finally, how do you measure the impact of what you're doing? Because we always want to make sure that what we're doing is actually working and having an impact. So we have some evaluation resources in there as well. And then also just wanted to draw your attention. I won't be able to show you everything here today, but we have a number of different resources, kind of non-data resources here, including impact stories, where you can hear how others have used the dashboard and what they've done in their communities. This is a new feature of the site, and we're really excited about it and really trying to grow it. And if there are any data wonks on the call with us today, all of these data are downloadable and accessible either through CSV files or through an API. So you can pull it all down into your own system and do any sort of analyses that you want. And if the data isn't there kind of in a format that you need, we're always happy to work with you and cut different files to help you do your own analyses. Yeah, and then again, there's a number of different other resources there as well. So that was a lot of information in I think a pretty short time. So any questions? I'll stop sharing, but I can pull that back up if it's helpful.
I have a question. How do you derive the data for the physical inactivity? I understand like mortality and how you pull those numbers, but how do you do the physical inactivity portion?
That is a great question, and it's actually a point that I always try and make, and I forgot to say today. All of our data comes from big national data sets. So the idea is that we're not going out to cities and asking them to give us their data, because it's just a huge burden with the number of cities. It's just not really a manageable task. And it would also mean that different cities would have different types of data. And we really want it to be comparable across cities. And for our smallest city, just about 50,000 population, to have the exact same measures as our biggest city. So the physical inactivity measure itself comes from the places data out of CDC. And so that is, those are measures from the Burfus survey that it's a telephone survey that gets sent out or that gets completed every single year, actually since I think about 1985. And then these data are modeled for every census tract in the country. And I can, or maybe if one of my colleagues could drop a link to the places site into the chat, you can get some more information there. And then all of our measures on those one pagers and even on just kind of in that metric information up top, you can find the data source. We have a really comprehensive technical document that goes through, where to find the data for, which ACS tables these are pulled from, our different calculation measures. So we want to be as transparent as possible for all of this. It's really important to us.
Thank you.
And I saw a question, how often is our data updated? And that's also a great question. So our data is updated as soon as we can, as the underlying source updates the data. So for this physical inactivity measure, again, it comes out of the CDC and they release New Year's of data every December. And so we're able to get or pull it after they release it on their site. We pull it into our systems, clean it, and then put it up on the site. And so they just released a new year of data for that measure very recently. And we're working on a data release for early spring that will include new places measures or New Year's of data for places, as well as a few other measures. So we tend to have about 2 or 3 data releases a year. We don't do it all at once because we know that the data is released on different schedules. So we want to try and get the data updated as soon as possible for each of those different data sets.
Anyone have any other? Mayor Tecklenburg.
Is it so, Shauna? I missed your introduction. Wow, that's a pretty remarkable tool y'all have put together. Wow. I think it's where did you come from? This is wonderful. Hey, so this seems like a great tool for us to use. Frankly, we've been talking about health disparities and focused on that life expectancy map of our own that DHEC, it mirrors what you've just shown us. How many cities have actually used this tool to come up with that quote action plan to address those disparities that exist?
That's a great question, and one that we are trying to understand a little more fully. So yeah. It's really hard to get that information. We have a number of cities that we work closely with, that we're able to get some of these impact stories or do other work with. And then, we come across, I've given presentations at conferences, and someone will come up to me and say, who I've never met before from a city we've never engaged with, and say, oh yeah, we used your data in our comprehensive city plan or something like that, which is, we always love. But I think a real challenge of ours is figuring out who's using it and how they're using it and how to really collect those stories. We do keep track. We have a Google Analytics page that allows us to see kind of very surface level information on the number of users, what our most popular measures are, what our most popular cities are. But it's really hard to put that together with kind of a really comprehensive understanding of how people are using it. But if you're interested in using it in a particular way, we can think through what cities that we are in closer touch with, that we are in contact with more regularly, that can maybe give you a sense, or that we could put you in touch with, who would be, I'm sure, happy to speak with you about how they've put it into practice in their city.
Well, that would be great. It would seem to me a wise thing for us to do if we want to pursue using this as a tool to come up with that action plan to talk to 2 or 3 other cities that you know well of that have been down this road and just get some, pointers from them and advice that might be helpful. Thank you.
Of course, yeah, we're more than happy to.
Any other questions for Shoshana? And if it's all right, I'll with Shoshana, I will ask if anyone else from NYU wanted to chime in or add something. We'd be happy to have you speak if you'd like.
I'll just chime in and say good morning. Thanks for having us. And please do feel free to reach out. You have all of our emails, I think, on the calendar invite. We're really happy to connect and walk folks through the data individually or connect you to other cities. So thanks again for taking a look.
Great. Thank you so much. And Shoshana, thank you. I've saved that site in my favorites on my desktop. I'll play with it a little bit, and I know I'll learn a lot from that. So thank you very much for that information. There are a couple of website links in the chat. So just to mention that as well for everyone. So Shoshana, you're welcome, and everybody's welcome to stay on. I see Paul has his hand up.
Well, I was curious. I pulled it up on my computer while we were talking, and if you went into the life expectancy and you take action, there's some good suggestions under find policies and programs and different areas that we could look at. And I just think those are the good options. We've been talking about health and all policies throughout our issues here, and so I just think having the resources at this thing, and I'm glad that the mayor suggested us look at other communities too, because anything we can do to help ourselves to streamline it, we were trying not to bite off too much at one time. We were trying to say, if we look at food insecurity and we looked at either access to healthcare, to built environment, and started just in 1 or 2 of these tracks where we're the lowest to see how we could change those numbers. It sounds like you've got some good track information there, and it looks like a lot of good tools here as well too. So we look forward to reaching out to you to just see how we can try to help connect some of those dots with us, that we could open some of those doors to spread it out. But I do think us thinking smaller into those tracks where we see those large numbers or the lowest populations is probably what we had talked about as our focus for the coming years. So thank you.
All right. Anyone else before we move along? Thank you again, Shoshana, and everyone from NYU. We appreciate you spending time with us and sharing this information with us. So thank you so much. So we'll move on to our community health update, and I'll call on Dr. Katie Richardson.
Good morning, everyone, and Happy New Year. I see she's joined us today, and we missed her the last couple of meetings. So I just want to start by saying, Tracy, do you want to give us an update locally before I start, or you're welcome to chime in at any time as well?
I won't offer too much except to let everybody know that the city rolled back to requiring masks for all employees as well as visitors on Tuesday, I guess yesterday. So hopefully this is just a temporary action while we're in this surge. But I'm happy to try to answer any questions anyone might have about city operations. But with that, I'll turn it over back to you.
Okay, thank you for joining us, and I'm certainly glad to hear that the city of Charleston has been using the data to alter their recommendations, their requirements for masks. And I also look forward to hearing from Charleston County School District and Maggie, and they too are responding to the increases to try to keep our community as healthy as possible. So we all know that we are in a spike of COVID-19 cases. Most of them now are known to be the Omicron variant. So we are following the trend that we saw in South Africa and Great Britain, with Omicron being a more transmissible variant and quickly taking over as the dominant variant in most parts of the world. Unfortunately, South Carolina has seen their highest cases ever in the pandemic. We had over 10,000 cases diagnosed on both January 1st and 2nd, and we see no signs that is slowing down. That rise is slowing down at this point in time. The Low Country saw an increase of over 228% from the week prior to Christmas to the week after Christmas, and I think that is going to we're going to continue to see even higher numbers in this coming week. Also did discuss in the media yesterday that we have had more than 1 million cases now here in South Carolina in the 22 months that the pandemic has been here with us. And I do just want to add the caveat that these numbers do not count at-home tests. So per CDC guidance, DHEC does not, at-home tests are not reportable to DHEC, and we do not count them in our case numbers. So the numbers, as we likely know from our own family and friends, there's certainly a lot of people testing at home and then using those results, as we do recommend, to make decisions about isolation and quarantine of close contacts. So definitely, just looking at Charleston County numbers over the past 3 weeks, we were at 339. The next week, 1,056. And this past week, over 3,002 cases. And again, we do expect those to continue to increase. And then when we look at how many people are testing, we're also seeing some of the highest percent positivity rates that we have during the pandemic. We're at more than 1 in 4 people testing are testing positive at this point in time. So that's sort of a brief rundown of the numbers. We are also seeing increases in hospitalization rates. We were up about 54% in those who are positive and hospitalized this past week compared to the week before. Those who are ventilated were up about 25%. So definitely not the increases we're seeing in cases. We do know that hospitalizations and deaths do follow several weeks from cases, but we do have some evidence from other parts of the world that our hospitalizations and deaths may not spike in the same way that they did, for instance, with Delta. And there's an article in the Post and Courier today, if you haven't read it, that gave some MUSC numbers and sort of feedback saying that those who are hospitalized are generally less ill than those during the wave that we saw with the Delta variant. But what we know is that the sheer numbers of positive cases could still overwhelm our hospitals. And I do see Meredith on, and we'll look forward to hearing sort of his take on what's going on at Roper right now. MUSC also stated that they're having so many employees call out. And no doubt all of you on this call know that is happening in your own organizations. But when that happens in healthcare, even with beds available, there are not necessarily staff available to care for those sick individuals. At the same time, I would be remiss if I did not mention flu, and that South Carolina is now in the highest transmission category for flu now, and the numbers do continue to increase. So we are potentially, entering a perfect storm of not only rapidly increasing cases of COVID, but flu as well, and the hospitalizations that do accompany flu every year. So, so just moving on to, and I do see something in the chat, so I just want to make sure that, no, that's not something that someone's asking. So I want to move on to guidance. So there've been a lot of changes in guidance coming from CDC. On the 27th of December, the CDC did release in the media updated and shortened recommendations for both isolation and quarantine for the general public. Populations. These do not apply to certain congregate settings like correctional facilities and homeless shelters, but do apply broadly and are specifically, it said that they do apply to schools and school-age kids. And as Paul mentions, the youth sports participation, we can talk more specifically about that, but the DHEC did release our school guidance revised document yesterday. And it does say that these isolation and quarantine guidelines do apply to sports and other high-risk activities such as vocal performances and theater. And so we're still waiting on the CDC's updated school guidance, and they may also weigh in on sports participation at that time. But as far as our school guidance around sports, we'll talk more about it, but part of the coming back early is wearing a well-fitting mask at all times. So it's not just the shortened guidance, but it's the shortened guidance with the other preventive measures in place. So yesterday, the CDC on their website did release their written guidance as well as frequently asked questions, just generally around their shortened isolation and quarantine recommendations. And I do recommend you check that out and share that with others, because there have been a lot of questions. No doubt you have all gotten a lot of questions. I certainly have. And so just briefly, what the isolation guidance is that regardless of vaccination status, someone who tests positive for COVID does need to isolate, i.e. stay home for at least 5 days. At that time, if they have no symptoms or if their symptoms are significantly improving, along with no fever for 24 hours without fever reducing medication, then that person could leave their home at that time. So that would be day 6 after 5 days at home, as long as they continue to wear a well-fitting mask around others for 5 additional days. So that's the bottom line for guidance around isolation. That's for those who are positive. Those who are close contacts or in need of quarantine, it's a little bit different depending on, various categories. So there is the person who is not maximally vaccinated. So that's a term that means if you are eligible for a booster, i.e. it's been 5 months since you had your Pfizer primary series, and that's a recent change from 6 months to 5. And we don't know what's going to happen with Moderna. So currently it's 6 months out from your primary series of Moderna, or 2 months out from your primary series of Johnson & Johnson. To be maximally vaccinated, you do need a booster at that point in time. So for those who are not maximally vaccinated and have been a close contact, the new recommendation is that person can return to work or to their usual activities after completing 5 days of quarantine at home. That quarantine begins after the last known close contact. So we again have the household contact recommendations that the person cannot isolate from the person who's positive in their home. Quarantine does not begin until after that person is released from isolation. So for instance, it doesn't begin until day 6. if that person meets the criteria for release after 5 days of isolation. And we do recommend a negative antigen test or PCR test prior then to being released from quarantine at that time. And then still the mask wearing for the additional sort of 10 days of the traditional quarantine. So Paul, I see that you say, what does fully vaccinated mean today? We did get that question, and to the letter of the law, fully vaccinated, it is getting that booster, and it is then 2 weeks after that. That is not that I have seen in writing, but that is what the CDC has meant by being maximally vaccinated or fully vaccinated in the past. I think so. For the purposes of quarantine, fully vaccinated now means needing that booster if you're eligible for it. For purposes of organizations saying you must be vaccinated not to have weekly tests and that sort of thing, I don't know that that has been fully clarified. So I don't know that the definition of fully vaccinated has changed across the board. But for the purposes of quarantine, it has now changed to include that booster. And then so the 5 days include 2 days prior. No. So the 2 days prior and 3 days after is really the evidence that CDC is using to base the 5 days. So we believe that a person is most infectious, most likely to transmit their infection 2 days prior to their symptoms beginning up through 3 days after their symptoms continuing. But the 5 days begins the first full day after the last exposure. And so, or after the positive test, or after the symptoms begin. So someone who's asymptomatic, tests today, it tests positive, the 5 days of isolation, we count day 1 as tomorrow. And then the release is day 6 if all those criteria are met. So that's one scenario of being a close contact. For those who are maximally vaccinated, so do have that booster if they're eligible for it. So someone who got their Moderna vaccine 2 months ago, they're not eligible for a booster yet. And so they would still be what we consider maximally vaccinated at this time. So that person still does not need to quarantine. We do continue to recommend that they get tested on day 5 after exposure. And again, they must wear a mask, a well-fitting mask for the 10 days after exposure. Likewise, for those who have tested positive in the last 90 days, that group also does not need to quarantine. There is some concern that Omicron variant, people who have had a recent infection with Delta, for instance, may be more susceptible to Omicron. That being said, the CDC chose to include this group, the recent prior infection, in the group that does not need to quarantine. But again, we do recommend testing on day 5 after the last exposure. And so I think those are sort of three big groups for quarantine that I want to cover. So just finishing up, I want to talk again about vaccination. We still strongly believe that vaccination is what's going to keep people safe during this surge of Omicron. We recommend anyone 16 and over get a booster as soon as they are eligible. And we talked about that criteria. As of this week, the FDA also granted EUA approval for a booster for those ages 12 to 15 who are now 5 months out of their primary series. They also granted approval for those who are immunocompromised and ages 5 to 11 to get a booster 1 month after their primary series. The ACIP, which is a group of the CDC that recommends on immunization practices, is meeting today. They may extend this sort of 5 months after Pfizer to Moderna as well. We'll just have to wait and see. But what we know is that South Carolina continues to be well below the national average in boosters. And so we have a lot of work to do to ensure that those who are eligible for their boosters are receiving them in our state. We continue to have over at 51% of our eligible residents having completed their primary series, 7.3% of those ages 5 to 11. And I don't have the specifics about how many are boosted, but it is well under half, more like a third of those who are eligible have received their booster. Testing continues to be very important. The federal government has said that they are working hard to increase availability of at-home tests. There are great resources on the CDC website, video resources for those using at-home tests on how to use them as well as how to interpret them. Certainly masking is very important, and I continue to recommend that well-fitting. So important now that the Omicron is more transmittable. So if you have access to KN95s, I think that is certainly very worthwhile as a consideration for wearing when out in the community. And then finally, flu vaccination continues to be extremely important. So I'm going to just go to the questions again. And Joey says, do we know if vaccination and booster rates differ greatly in ethnicity? That is a great question, Joey. What we know is that the disparities in vaccinations have decreased with time here in South Carolina, and I think nationally. I don't know if I've seen those results about boosters yet. I would suspect that there's more disparity in boosters than the primary series at this point in time. I do believe that there's we've certainly seen long lines for testing, and we've heard about people having difficulty finding testing. I personally have not heard that with vaccinations. I took my 15-year-old to get her booster the day it was available. There was no wait at all at the MUSC Lockwood site. We walked in without an appointment. They saw us immediately, and we were in and out of there in less than half an hour, even with the 15-minute wait. So I believe that access to vaccinations is still widely available. We can always do more to taking vaccines to where people are. And DHEC continues to work with organizations across the Lowcountry, across the state. So if you do know of organizations that would like to have vaccination clinics, certainly, reach out to us about that. Our Vax locator and testing locator sites have gotten a lot of traffic recently and continue to be great sources for where to be able to get testing in our communities and where vaccinations are available. And it includes which vaccines are available where for those looking for a particular vaccine for the booster. All right, let me go back up and see.
Kimbo had a question on the chat.
Okay. Do you know the status on the federal government's plan to mail at-home COVID tests for free? I have heard that is happening. I don't have a specific date for when that would be rolled out. I had heard originally January, sort of middle to late January, but I have not heard an update in the past week or two. And then, we didn't touch on treatments, but what I can say generally is our recommendation is to reach out to your provider. If you do test positive and feel like you are at risk for more severe consequences, there are now 2 oral medications, as well as one of our monoclonal antibodies continues to be effective against Omicron. The bottom line is that all of those are in short supply now. There are many more people who qualify, who could benefit from them, but they are just, there's too many people that are in need. That being said, there is availability in South Carolina of all of those options, and that, as always, is through your provider. That's, I did want to just mention that. Did I miss any questions? Or are there any other questions out there?
Thank you. Did you had mentioned Meredith Belinsky. I don't know if you had something specific that you wanted him to chat in on. And
well, Meredith, it would be great to just hear what are things like inside the walls of an acute care hospital these days.
Hi there. Good morning. And I think my laptop actually has COVID because I can't get the camera to work. But actually, we kind of felt a little break after Delta. Pretty much it didn't die down, but I mean, we got a lot of our patients healthy and out, and now we're ramped up again. So we've gone back to square one. We're limiting patients coming in, visitors coming in to see patients. We have an average of about 50 patients a day waiting outside of our express cares to be treated, to be seen, to be tested. And sometimes in our ERs, our physicians are evaluating the patients in the side waiting rooms, just on the outside. So it's we have I'd say just in St. Francis there's 16. In our system right now we have 53 caring for inside. And like you said, the scare isn't, we don't know if it's going to be like Delta, but it just by way of how ill it's going to make each person, but it is more, you're more susceptible to getting it. It is highly transmissible. So I know our world is sick of masks, but like Katie was saying, it's so important. This and the masks, people don't really take for granted, that they don't understand, or the masks are for everyone else. You're helping other people. So if everyone's doing it, helping someone else, then everyone keeps a mask on, and we keep what we have to ourselves, and that's the whole point. So yeah, we're seeing the spike again, and we're preparing for it. And we did very well through the last spike, and we're hoping to do the same here. But we've limited our meetings with just internal leaders and whatnot. So everything's gone back to square one, like it was initially, where we didn't get the big hit, then we got the hit with Delta. So Omicron is we're treating it the same, because we are seeing a heavy spike in our system.
Meredith, and can I add something to that at Roper St.
Yes.
Francis? So it's not even the patients that are coming in, but our teammates. We've seen a great big spike in teammates that are out. And so if you visit any of our facilities, you'll notice that wait times are much longer, not just because of patient volume, but because of personnel volume. And so we're struggling in our express cares, especially because there are in our outpatient facilities, because they tend to be in contact with more people. So again, masking is great for operations and for patients.
Yeah, thanks, Kim. Actually, they just had the St. Francis just did their update this morning, and about every second or third department that chimed in, it was I have one out with COVID, 2 out with COVID. So it is spreading our system too. But I'm sure like you've seen, we're extremely clean, to the point of OCD clean in our systems. So we want everyone to come see us, because that's what we're here for. But we are very clean in how we take care of ourselves and our teammates. So yeah, but it's the first one that's actually spread heavily through our system too. But those teammates know what to do. Like Katie said, you stay home, you isolate yourself, quarantine, and we get through this together.
Great, thank you. Paul, did you have a question?
Okay. Katie, I wanted to go back to the isolation because I just want to make sure I understood it. If I had COVID, I tested positive for COVID, but was asymptomatic when I tested. If on day 4 I started having symptoms like a cold or something, am I still able, and my cold clears up on, say, day 5 or day 6, am I still going to have to do additional days for isolation?
Yes. So the CDC has changed their guidance to say, given the shortened isolation, those who are asymptomatic at the time that they test positive, but subsequently become symptomatic, that 5 days begins again at the time that symptom onset happens. So that is a caveat for those who are asymptomatic. We're certainly, because there's just more testing going on, some of that required by people's organizations. We are picking up asymptomatic cases that then in the coming days become symptomatic. We do recommend, DHEC and the CDC, that then that 5-day time clock restarts at that time.
And then one more question. Okay, so my spouse comes down with COVID. So my last time so she starts on day 1. Should I test on day 5? I might not be able to isolate from her, or do I wait till after day 5 and then I test?
So
if I'm trying to
it's sort of right. It sort of depends on, can you figure out, how your wife may have become positive. And if you had that same exposure, then you would want to test immediately. If you know you did not have that same exposure, then our recommendation is to test 5 days after the known exposure, and then again 5 days after your last exposure. So if you're not able to isolate, that is testing at least twice. And if you potentially had the same exposure as your wife, that would really be probably 3 times, where you're testing immediately, then you're testing after 5 days, and then you're testing again after another 5 days. And that's really, whether it's an at-home test, it's an antigen test with the provider, it's a PCR test, that knowing your status, knowing whether you're positive or not, is going to very much help us to prevent the transmission further in our communities.
Thank you.
All right, great. Any other questions for Dr. Richardson? I did want to just call on Maggie Dangerfield for Charleston County Schools, because she just, Charleston County obviously just opened back up yesterday to thousands of students, teachers, and staff. So Maggie, just wanted to see if you had anything.
Sure. Thank you so much for the opportunity to share. We did welcome back staff on Monday and students yesterday for the start of the new year. Kind of to echo everything Dr. Richardson explained, we are aligning our quarantine and isolation guidelines with those that DHEC has shared for schools that were revised on December 31st, 2021. We have updated that information on our website as well. But essentially, quarantining for at least 5 days since the symptoms started for positives, masks being worn 5 to 10 days, and then asymptomatics cases with a positive viral test or have to be excluded from school until at least 5 days after their test was taken. So all of that is available on our website. Our Board of Trustees has policy ADD that prior to the break, they had said, based on the DHEC incident rate and metrics, if we were in medium and high, that our mask requirement and enforcement would go into effect when we came back. So we are in that period again, and our mask requirement is in effect from January 3rd through at least January 14th. We have an upcoming Board of Trustees Committee of the Whole meeting and special called meeting on Monday, the 10th. And of course, they'll reassess that based on our current data as well. We also have had some COVID testing sites at our facilities for staff and students over the break, with Monday being a large effort to kind of help our staff and students get a test before coming back to school on Tuesday. We, before the break, had ongoing testing sites Monday, Wednesday, Friday, and Tuesday, Thursdays, and Saturdays at certain locations around the county. I do believe the plan is to continue those. I don't have confirmation on that. I was asking about that this morning, and Dr. Richardson, you may know more on that, but certainly if those are still going, they're after school in different parts of our county to help support those efforts. And then probably the biggest piece of news over the break, our superintendent resigned. And so we have a new interim superintendent of schools, Don Kennedy. He is our CFAO, our Chief Financial and Administrative Officer, who has stepped into that role interimly. So he stepped into that role officially on Tuesday.
Okay, very good. Any questions for Maggie or for Charleston County Schools from anyone?
I did put in the chat that those testing sites are ongoing. They are for everyone associated with the school community, but not open to the general public.
Great, thank you.
Yes, thank you.
All right, we are at 10:05. I won't go around the horn, but I do want to make sure that everybody that needed to say something has had an opportunity. If anyone else has anything. All right, well, if not, I want to say thank you to everybody for joining in. I know it's a busy week for a lot of people, so thank you for your time, and thank you for all that you do in our community, and wish everybody a happy new year, and we will see you next month, if not before. So thank you so much.
Thanks, Councilmember Shealy.
Well, everyone.
Thank you, Lori. Thank you.